Hi, everyone. Sorry, let me just go back to the opening. What is going on here? Sorry about that. Yeah, so thank you very much. Today, we're just going to concentrate a bit on flail chest and thoracic trauma in the emergency department. And it's more of a refresher course because we have done this topic before. But now, coming towards the end of the year, I think it would be much better for us to just have a go over before the real silly season starts and patients start coming in with all of these problems. My apologies for doing a pre-recorded one again. Unfortunately, my as my health issues continue to cause a problem, the medication that I'm using sometimes makes it very difficult for me to teach you guys. But hopefully from next week should be a bit better. And yeah, as I was telling one of the doctors who had messaged me to wish me well, that I sometimes end up giggling and slurring because of the medication and especially the muscle relaxants and oxycontin. Even though I've taken it today, I'm hoping it hasn't kicked in already and I'll be able to teach you guys quite well before anything gets worse or before I get any more affected by the medication. Right. So let's get into this and let's just talk about it. Sorry, just trying to get this. So thoracic trauma, one of the most commonly seen traumas in most of our settings, and it's often associated with penetrating and blunt abdominal trauma as well. And penetrating chest trauma, I think, is one of the most common traumas that we see in our South African context with knife wounds and stab wounds, I mean, and of course gunshots and things like that. So it's extremely problematic for us, and it's a high burden of disease and takes a lot of resources for us to manage these patients. And of course, in terms of death, you'll find that your abdominal, neurological, and abdominal cardiothoracic and neurosurgical trauma, of course, are the biggest contributors with lung trauma and bladder trauma and those, counting for much less, the thing is, when a patient does have thoracic trauma, the main things that we are worried about, number one, is cardiac tamponade. And with cardiac tamponade, you can bundle in tension pneumothorax. The reason being the pathophysiology behind death is the same, where it's essentially a squeezing down on the myocardium. Eventually the myocardium is unable to expand, and therefore is unable to contract, is unable to pull blood into the heart. Especially with the tension pneumothorax, it's more common, but eventually, even with the cardiac tamponade, the right ventricle is unable to expand, so it can't bring in blood, so it can't take out blood. That's basically what happens. Massive hemothorax, not a nice thing to see, but when we do see it, it is something that is quite dramatic because your patient can exsanguinate very easily if one of the larger vessels in the chest are hit. Um, Currently in South Africa, we're using the Sanape IC drains in a lot of the hospitals, and they work as auto transfuses as well. So blood goes into the IC drain and then can be auto transfused back into your patient. And it's quite an easy system to use, quite a simple system to use. And if you don't have those, even with some of the older ones, you uh, at least have to keep an eye out for how much your patient is bleeding. So generally, if your patient bleeds out a full bottle, about 1,500 mils, your patient needs therapy immediately. Or if your patient has lost more than 250 mils per hour for at least 4 hours in a row. My advice would be that if your patient is bleeding, even if they're approximately within those barriers. I mean, if patient has immediately lost 1,200 mils, or your patient is bleeding out 240 mils per hour, you should get your surgeons involved. Be they available locally or you have to transfer your patient. But ideally, you shouldn't be watching this patient in a rural or semi-rural setting or in any setting without a surgical specialist or experienced surgical team to look after the patient. When I say that, I mean somebody who can go in and do thoracotomy and have a look at the patient because emergency department thoracotomies, even though they are done, if you're not experienced, you can actually do well, I wouldn't say more harm than good, but the potential for you to cause very significant problems for the patient thereafter in terms of nerve damage, muscle damage, bone damage extremely high. So I would stay away from it unless you know exactly what you're doing. You have a set available. I've seen and heard of anecdotes of people trying to do thoracotomies without the proper sets and chest spreaders and light, and they really just cause more problems than what they solve, and the patients normally don't make it anyway, so they just put themselves in trouble or cause troubles for themselves. Airway obstruction are generally not associated with trauma, but tracheal injuries, injuries to, the large airways, they can sometimes, and of course, inhaled, foreign bodies, things like that, and blunt trauma directly through the chest generally won't affect the large airways, but it can affect the trachea. So that is something that you need to watch out for. And flail chest, which is something we'll talk about more in this presentation than other things, of course, your patient is unable to ventilate themselves, if I can put it that way, because the larger the area that's affected by the flail chest, in other words, the more ribs that are involved, when your patient breathes in, that lung is not expanding, so it's not being ventilated. And when your patient is breathing out, the air that's there is not being expelled. So your patient starts going into respiratory failure based on that. Secondly, they also have a lot of pain associated with this, so it's very difficult for them to actually ventilate properly, And there's some quite dramatic videos and things that I've seen online. Most of them are copyrighted, so I couldn't put them on here. I don't have any problems with those people who have actually posted these before. But it's quite dramatic, and it's something that you should be able to identify clinically. And of course, a simple pneumothorax, while not immediately life-threatening, cannot be left as well, because as your patient continues to breathe and expel air from the chest cavity, their lung will continue to get smaller and smaller and smaller, and eventually they won't be able to ventilate, And if it should be bilateral or something like that, it can be quite a problem. So what do you do when you get these patients? So the first and most obvious thing is try and get as good a history as you can from the pre-hospital EMRS, whoever may bring the patient in. And this is especially true during MVAs. One thing I've often found people not take into account is the seriousness of accidents or PVAs and things like that. So, if for any reason you can get, the velocity of the impact, whether the patient was restrained, unrestrained, whether there were other deaths at the scene, things like this. These are all important things for you to know. So, for example, your patient may be alive and may look relatively stable, but four other people died in the car. This lets you know that there's a good chance your patient may have quite severe injuries, that may be being masked. If your patient, for example, was a pedestrian, there's witness reports that the car was on, let's say on a national highway speeding. If somebody hit at 140 kilometers and somebody hit at 40 kilometers an hour, I'm going to give you two completely different clinical pictures, And of course, it will also tell you to look for associated injuries and things like that. But the first thing we do is we focus on the basics, which is airway, breathing, circulation, our advanced trauma principles. So we go from head to toe. Even though we're suspecting, let's say, thoracic trauma, we still go from head to toe. I'm a big proponent of not focusing on the flashing red light. So, often your patients will come in with one very obvious big thing. Don't just focus on that. Look for other injuries, because sometimes those can embarrass you if you miss them. Of course, you look for open chest wounds, things like that. And of course, flail chest, which is often associated with high energy trauma, falls, things like that. Yeah. All right. So let's get on to the next part. So how do you manage it? Patient needs oxygen. They've got thoracic trauma. If your patient is in respiratory distress or unstable, try and intubate as quickly as possible. If you're lucky enough to be able to get an ABG very quickly, look for hypoxemia or look for hypercarbia. So either one would point to respiratory failure, one or two, and you know that you need to intubate, especially given history and things like that. If you suspect a tension pneumothorax, the best thing you can do is decompress by a needle thoracostomy. So you stick a needle in the second intercostal space, on the side that's affected. Of course, please don't do it on the other side. You're just going to poke the lung and do it on the side that's I'm sorry to point that out, but sometimes it's quite amazing. In the heat of the moment, people get that. So do it on the side that's affected. Look for your tracheal deviation, and how you know it's improving. Two things. Number one, they always tell you to listen for the gush of air, but also look for the trachea moving back to its normal spot. It happens quite quickly. And if you remember to look for it, it's quite an amazing thing to actually just see that trachea shift as you're doing it. And of course, you resuscitate your patient from a circulatory point of view as well. So what about an open pneumothorax, a sucking chest wound? If you have a sucking chest wound, that implies that the lung is going to collapse quite quickly. This is why we worry about it. And once that lung collapses, your patient is only ventilating one lung. And as compared to somebody who's had long-standing lung disease, a normal human can't ventilate with a single lung. So the best thing to do is actually close off that wound with the three-sided dressing, which I'll show you now. But do not use a full dressing because then you make it a tension pneumothorax. And you can, of course, insert an IC drain. And, once you've got an IC drain in there, then you put on a full dressing. It's not a problem at all. So this is how your three-sided dressing works. So you can leave one side completely open or just a flap. It just depends what works on that particular patient and the positioning of the wound and things like that. Basically, what needs to happen is that when your patient bleeds out, air must escape. If air is not escaping, you haven't left enough of the space, you haven't brought it close enough to the wound. So, for example, you may, for example, say, okay, Dr. Mohammed showed us this, I'm only going to use this. But now you've got, for example, a very long way for the air to travel. It's not coming out. You may need to open up this side. You may need to close this side. You may need to keep this side open and these three sides closed. So really, it depends on that particular patient and that particular wound. This is just an example. And when your patient bleeds in, then that flap should close. So it's acting like a valve. So it's allowing air to escape, but not allowing air to get back in. So what this does is twofold. It's not allowing your lung to really re-expand, but at least it's not collapsing more. And it's sort of aiding a little bit in terms of re-expansion. The reason being that there is no longer that how to explain, collection of air now that is sitting in that thoracic cavity. So it really helps quite a bit. And on the road, I always remember most of the ATLS courses I went for, we were told use our credit cards, use something like that. But then with the amount of credit card fraud that went on, they kind of moved away. So now I would suggest probably using your SAMA card, your NPS card, any one of your medical cards, because people are more likely to return that to you. And if worse comes to worse, pick one of your macro cards or something like that. You won't lose a lot of money. So let's talk about a flail chest. So what is a flail chest? So flail chest merely means that the 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 the, the ribs have been fractured in two places, or you've got a fracture of the rib and the sternum, or you've got a single fracture to the floating ribs, which means that that particular part of the chest is no longer connected to the rest of the thoracic cage. That's basically what a flail chest is. So it's generally caused by high energy blunt trauma. And as I said, it's in two or more fractures in two or more contiguous ribs. So it's very difficult to have a flail chest on a single rib. It's still worrying if you have two fractures on a single rib, but less likely to cause a flail chest and less likely to cause hypoventilation. However, once you start having two or more, then you do start having. The paradoxical chest movement is very easy to see. When your patient bleeds in, the flail chest, the area that's flail collapses instead of expanding outwards. And when your patient breathes out, that particular area pops out instead of going back in. So that's basically what we've got over there. Now, there was a lovely video that was available, but it was copyrighted. And there was a lovely GIF, I think that's how it's pronounced, that's also available online, but it's also copyrighted. Both of them are quite extreme, but I would suggest if you have a chance, go and Google them. Flail chest, the video, flail chest GIF. Both are from America, and the one shows a young man bent over following, I think it's a motorcycle accident, and it's the most extreme case I've seen. It's probably about 5 or 6 ribs involved, but it gives you a clear idea, especially if you're a student listening to this and you've never seen a flail chest. But for those of us who have worked in emergencies, you've probably seen the flail chest before. So, like I said, it's normally a fracture of of a rib in two places, or you can have, for example, a fracture through the sternum plus a fracture through the ribs, and then occasionally you can have a fracture through the floating ribs at the bottom. Now, when that happens, there's often also rotation of the rib because of a discontinuation with the cartilage. So there's also a fracture along the cartilage and bony border. So you often get rotation of the ribs. Now, if you have a chance, go back into our videos. There's a lovely presentation that I've done before on chest trauma, where we go through a few examples of Flail chests and looking at the X-rays and different types of X-rays and different types of Flail chests. And if you haven't had the chance to find one in X-ray, it does give you a chance to do that. If you have access, of course, to CT scan or any type of other imaging, though that also comes in extremely handy if you can stabilize your patient and get them there. So your clinical diagnosis is based on the mechanism and exam. It's not really radiographic, but sometimes when you've got a very small flail chest, your X-rays do help to confirm the diagnosis. CT can help you confirm the diagnosis. The thing is, you do have to have a low threshold for intubation because these patients suddenly become incapable of breathing on their own. So they may either, suddenly become hypoxemic, so you see your stats just drop down. Alternatively, they're slowly building up their carbon dioxide, and they suddenly go into, this type of respiratory failure, and it tends to happen very quickly. So I was always very scared when it came to flail chest. If the patient showed any sort of decrease, even if they were ventilating at about 86 or 87, relatively stable, I would still try and intubate them. If the patient was showing signs of distress in terms of pain, in terms of inability to talk, speaking, almost like an asthmatic patient, speaking in single words, trying to, be or starting to become restless, we would immediately intubate and try and sedate and give as much analgesia as possible. Now, one of the things that can help you stretch out your time for intubation is if you know how to give a what you call it, intercostal nerve block. But if you're not experienced in that, I wouldn't attempt trying it on an acute patient. It's probably something you can try in a skills lab or during anesthetic rotations and things like that. However, even in giving that, it's more for pain relief, and it can sort of give you an extra couple of minutes, maybe 20 minutes or half an hour, because your patient is able to ventilate themselves because there's decreased pain. But it's not that you're going to get away from intubation if your patient has a significant flail chest. Should your patient be relatively stable, there is a flail chest, ventilating properly, it's the type of patient that you now need to ask a surgical or trauma department what they would prefer. Now, most of them would prefer intubation regardless, and then you continue on from there. And some of them, well, they would come and make the decisions on their own. It just depends the setting in which you're working. If you're working in a rural area, community health center, clinic, I would intubate and then transfer out. I wouldn't even take a chance because these patients are notoriously, like I say, fickle. They're very brittle. They can just suddenly change. And of course, an IC drain should be placed. Now the question comes, okay, I've got a flail chest, but I don't have an acute pneumothorax. Should I still put an IC drain? I would say no. If you don't have an acute pneumothorax, don't rush to put an IC drain. However, if you have signs like a decreased air entry, surgical emphysema, but maybe on X-ray you can't see it, I would go ahead and put in the IC drain because the chances are it may be just small pneumothorax that's going to get worse. And sometimes you may also have an apical pneumothorax that's, especially in acute trauma where a patient maybe has been brought directly from the scene to you, and you don't have a lot of time between when the injury occurred for enough air to collect to show a huge pneumothorax. Okay. So let's have a look here. So there's a few things to note in this section. Number one, you can see there's the IC drain going in here. Here's another IC drain going in there. So that's a double IC drain. The first thing you notice with this IC drain, it's not gone in quite well. So that double drains are not uncommon. However, this is a poorly placed drain. The second thing you'll notice is that there's rotation of the X-ray. It's not that everything's being moved. The way that you can make this out is by the length of the ribs. You can see this side slightly lengthened compared to the others. I don't think you can see the clavicles here, but if you could, you would probably notice it as well. Now, the one thing that we notice, and one thing that makes radiographs very difficult in terms of diagnosing these, there's often underlying confusions as well. Here you can see a bit of surgical emphysema that's present, and here we can start seeing the ribs. So the best way I've often found to look at chest X-rays and see if there's rib fractures, sorry, is to have a look at the line that connects each and every bend of each rib. So if it forms a straight, almost continuous line, chances are your ribs are okay. But once you come and you start to notice that there's dips and there's valleys and mountains and things like that, then chances are there is something wrong, even if you can't make it out. Like for example, in this one, it's quite obvious, but in some it may not be, especially if there's anterior fractures and things like that. But here we have a massive lung contusion, and the way that you know that there's a lung contusion, besides looking at the radiograph, is of course when you intubate, you'll find a large amount of blood that's coming out. Now here we can see the rib fractures here. If you follow now, we're on the first, second, third rib. You can see that the fourth rib is okay, and it's probably here on the fifth, and here on the sixth as well. Probably on the, oops, sorry about that. These were some of the gifts that I managed to get, but anyway, I was going to show you that. Just not sorry about that, something just slipped over there. And so you can see there's obviously a lot of trauma that's going on over there. Okay. So once you see it, it's very difficult to miss it after that. This is a CT scan showing some of those fractures as well. So here you can see where CT can be of benefit. Because here again, we've got a lung confusion. Now, it's not really masking the fractures, but it is masking the fractures behind the cardiac border. So even though you can see one there, but what about the others? Can you see them? It's very difficult, and your patient may have signs clinically of a Flail chest, and that's where you start getting the what you call it, the CT scan indication. So you can see 1, 2, 3, 4, 5, 6 rib fractures, and 1, 2, 3, 4, 5. In any case, this patient wouldn't probably be ventilating too well. Here we can see the surgical emphysema that's building up again, and that tells you that you need to intubate the patient, of course, which hasn't happened yet for this patient. But it just shows you how valuable CT can be, especially if some of the fractures are hidden behind the cardiac border, the gastric bubble on the other side, behind the liver, and things like that. So, and of course, CT can also show you underlying injuries, such as, penetration into the kidneys and the liver and the stomach and things like that. So you can see those as well. And of course, some of them you'll pick up if you do fast, you'll pick those up as well. So here's some of the Flail chests that I did manage to get hold of. This one here it's a nice one. You can see the movement, but these are not the best. There are some better ones, like I was describing. One of the gentleman was in a car accident. You could see that much better. But here you can see that typical movement. So when the chest is when the patient is inspiring, the chest collapses, and when they expire, the chest pops out. And the same thing here. Here you can actually see the bruising along where the rib fractures are. And there, if you watch properly, you can see when there's inspiration. If you look at the other side, you can see the other side lift up, this side will fall down, and the exact opposite happens. You can even match it with uh, the pumping of the bag here. So you can see when the doctor does an inspiratory bag, pumps air in, you can see the lung collapsing. Okay. All right. So what do you do further? ICU admission is probably most appropriate for most of these patients. Pain control, epidurals, regional blocks, if you are experienced. I wouldn't advise them in the emergency department unless you're a very experienced medical officer or you have many years under your belt or you're a consultant. I wouldn't advise it if you're a junior doctor. It shouldn't be your first point of call, but it's just to let you know that these are possibilities. And of course, pulmonary toilet, which is your IC drain, and that of course is going to help you quite a bit as well. So what's the difference between a Flail chest and a simple pneumothorax? Flail chest, multiple rib fractures, and it's often associated with pneumothorax and pneumothorax. Open pneumothorax is often associated with penetrating chest wounds with air entering the pleural space and can be managed with a occlusive dressing and tube thoracostomy or intercostal drain insertion. So, in conclusion, uh, early identification and management is extremely vital for mortality, and you need to recognize that they're just sucking, open pneumothorax, extension pneumothorax, cardiac tamponade, all those that I mentioned earlier are all life-threatening conditions, you know. So I hope you guys did learn something. This is, of course, our lab techs who sometimes are called to assist to pull blood. So phlebotomy, how do you pronounce that word now? The vein people from the labs, phlebotomy. It's called. I'm sorry. I think my oxycontin is starting to kick in. So anyway, I'm of course very providing is one of my favorites. Really enjoy it. Okay. Like I said, the last season, the first season, amazing. Yes, targets for that. It's probably the only current Star Wars thing I'm actually excited to actually keep an eye out for. So, in any case, I just say a little bit like some positive things, but as for the man in the chest with the shocky shocks, which is an interesting way of putting it. So, if you have any questions, more than welcome to ask me on the group or post in the YouTube comment section. And thank you so much for all of you who did watch this. And my apologies again that we couldn't have it as a live session. But I hope you'll understand why, and hopefully we will have one next week. Okay. Thank you very much, everybody. I really appreciate it, and we can keep well. Bye.